Hello everyone, we've got quite a few people still joining the webinar, but we'll make a start while people do join. So welcome, my name is Donna Glover, I'm the Programme Manager for Learning Disability in Public Health England. We're recording the webinar today and all being well, we should be able to publish a recording of it, which we will circulate a link to. This is part of a series of webinars that Public Health England host about the health of people with a learning disability. If you'd like to sign up to the series, then do drop us an email. We'll have our email address visible at lots of points through the webinar. So the structure of this webinar is that we're going to start with Giles Glover from Public Health England talking about some data about the early deaths of people with a learning disability. That's then going to be followed by Pauline Heslov from the Mortality Review team in Bristol, who's kindly agreed to join us today, and then by John Trevaines, who again has kindly agreed to join us from NHS England. So just a few very brief ground rules. Everyone is muted for the purpose of the webinar so we don't get lots of background noise. If you have any questions as we're going through the slides, then do email them in, and we'll see if there are any sort of themes that are coming through there. If we have time before the end of the main part of the webinar, which finishes at 12:30, for me to ask some of those questions to the presenters, then we will. But we will then remain online for another 15 minutes to do some questions and answers, and we will then open up the lines gradually, and I'll explain how we do that towards the end so that you can ask some questions. If we don't get to you, or if you have a question, if you're watching this on the recording, then do email us. So there's the email address there, ldt@phe.gov.uk. And just to say, the slides are an overview. There are lots of links in them for more information, and there are some slides right at the end which give links to some more resources. So I'm going to hand you over to Giles Glover.
Hello. This webinar is about people with learning disabilities dying too young. I'm going to say a bit about the numbers of people involved. I'm going to talk briefly about three aspects of this. First, a bit about the trends. Second, a bit about how death rates for people with learning disabilities compare with death rates for other people. And third, a bit about estimating likely local numbers. So if we have the next slide, please. So, studies of deaths of people with learning disabilities often make an estimate of their life expectancy, looking at a figure called the median age at death. So I thought it's worth being clear about exactly what we mean by this. The figure you can see at the bottom of this slide, slide 4, shows 21 deceased people and gives the age at death for each one. These are in order. So the middle one is marked in green. This person died at 60, 10 died younger, 10 older. So the median age at death, the middle one, is 60. This isn't the same as the average death. The average for this group would be 43. But when the pattern of ages at death has got bunches in it, like this one has, it's a more useful way of encapsulating something about what age an average person can expect to die. We use this calculation instead of the more formal life expectancy calculation that statisticians use because we haven't got the data to do the more satisfactory calculation over a long period. The next two slides show how this value has moved over the last 16 years for people whose death certificates make it clear that they had a learning disability, and for people whose death certificates makes no mention of learning disability by comparison. So in slide 5, we do this separately for men and women because in the general population women die at older ages than men, and the gender ratio for people having a learning disability is different from the general population gender ratio. So slide 5 shows the pattern for men. The median age at death for those without recorded learning disability has risen over this 15 years period or so from 76 to 79. The figure for those who are identified as having a learning disability rose from 53 in 2001 to 60 in 2014 and 15 before dropping back to 59 in 2016. Now, it's important to say the confidence interval bars on this for people with learning disabilities are much wider because the numbers are smaller. So a shift of 1 year up or down could simply be random fluctuation and shouldn't be taken as meaning anything particular. But the overall trend is clear enough. The gap in age at death is closing and has been over most of this period. So if we go to the next slide, Slide 6 shows that for women, the gap is larger. Now, Donna, could you please flip the slides backward and forward a couple of times to show that difference? Women without learning disabilities die at older ages than men without, whilst women with learning disabilities die, if anything, at younger ages than men with learning disabilities. If we can go on to the next slide, slide 7 is just a reminder that this has been a hot topic for at least the last 15 years. It shows the pattern for men with a few key dates on top of it. The MenCap report, Treat Me Right, was published in 2004. The Disability Rights Commission published Equal Treatment in 2006. In 2007, Beverly Dawkins' wonderful book, Death by Indifference, was published by MenCap. This gave rise to the 2009 Michael Report. In 2010, the Department of Health set up the Learning Disabilities Observatory and the Confidential Inquiry. In 2013, the Confidential Inquiry published their great SIPOLD report. And in 2015, quite near the end of this slide, the LEADER programme was started work. So high mortality rates have been a key concern for all this period. If we can go on to the next slide, please. Slide 8 shows another way of looking at this. A simple death rate is the number of people who die in a period divided by the number in the population. But the population of people with learning disabilities is younger and more male than the general population, and death rates rise with age and differ by gender. Standardized mortality rates compare the number of deaths in a group with the number that would have occurred if they had some standard expected set of death rates for each age and sex group. This slide and the next use different sets of expected rates to answer two different questions. This one considers how much greater learning disability death rates are than general population ones. It assumes people with learning disability ought to have the same age and sex death rates as the whole population of England. And it shows data from all the general practices in England that NHS Digital can get data from the Learning Disability Health and Care dataset. I've talked about that in other webinars. It's just over half the country's population. The table shows the actual number of deaths is about 3 times this expected figure. The excess is greater for women than for men. And this chart shows the chart alongside shows the 3 years for women and for men alongside each other. The confidence intervals on those give you some sense of how big a shift we would need to say that any movement is significant. So there's some suggestion of a downward movement in the figure for women, but we should really wait and see what next year's data show, while the figure for men show no appreciable trend at all. If we can go to the next slide, slide 9, shows how you ask if any local area is better or worse than any other area. So in this case, the expected death rates are those for people with a learning disability for the whole of England. So a place performing averagely would score 1 on that basis. And numbers for local areas are obviously much smaller, so the confidence intervals for these bars are much wider. I've marked the 1 line, which is the no different from average line, in bold. Anywhere the confidence interval doesn't cross that line is doing better or worse than the country as a whole. So we can see that 2 of the London sub-regions, North and Central and South, have got some significantly low figures. But the main point I want to make in this slide is that the numbers of deaths are really quite small for making comparisons even between sub-regions. They're too small for any sensible comparisons between CCGs, except for quite long periods, 5 years or more. Could we have a next slide, please? Slide 10 addresses the practical question of how many deaths a local mortality review group should be planning for. I've assumed again that people with learning disabilities should have the same age-sex specific death rates everywhere in the country. The simplest way to work out how many deaths to expect is to take the number of people on your local QOF register, your local QOF learning disability register, and multiply this by 0.125, which is 12.5 per thousand, which is the crude death rate nationally for people with learning disabilities. Ideally, for local planning, you'd want to have a better idea of your local population with learning disabilities, and you might want to know their age and sex breakdown as well as their disability characteristics in a local learning disabilities register. If you at least have their age and sex breakdown, then the age and sex specific rates I've shown in the table will let you work out a more precise estimate. So I'm going to wish you all a great Learning Disabilities Week. Try and do one thing that improves things for people with learning disabilities by the end of Friday, and hand over to Pauline.
Thanks very much, Giles. So my name is Pauline Heslov. I'm the programme lead for the Learning Disability Mortality Review programme. I'm based in Bristol. The Learning Disability Mortality Review programme, we call it the LEADER programme for short, aims to support local areas to review the deaths of people with learning disabilities aged 4 years and over, and to take forward the findings of the reviews into service improvements. In this part of the webinar, I'm going to discuss the findings from the LEADER programme that were recently published in the annual report for 2016 to 17. You can find a copy of the annual report on the LEADER programme website, along with an easy read version. So the data relates to deaths that were reviewed between July 2016 and the end of November 2017. So can we have the next slide, please? So this slide shows the demographic details about those people with learning disabilities whose deaths were reported to the LEADER programme. The number in brackets beside each bullet point shows the baseline number for the detail under consideration. So you can see that of 1,311 deaths that were notified to the programme, 57% were male, 43% were females, and that's approximately the breakdown that we would expect. Slightly fewer reports recorded the ethnic group of the person who had died. Of 1,145 reports that did record this data, 93% stated that the person was from a white ethnic background. And that is a greater proportion than we would expect. So we'll be working with local areas to increase the notification of deaths of people from Black and minority ethnic groups. Approximately 1 in 10 of those who had died had lived alone, and a similar proportion had been in an out-of-area placement when they died. And the proportion of people dying in hospital at 64% was greater than the proportion in the general population who die in hospital at 47%. The next slide shows the findings regarding the age at death. So the median age at death, as Giles explained, for people with learning disabilities who had died was 58 years. Remember that this relates to people with learning disabilities aged between 4 years and over when they died. The youngest person who died was indeed 4 years. The oldest was aged 97 years. And the median age at death for males was 59 years and for women 56 years. The data therefore suggests that men with learning disabilities died 23 years younger than men in the general population, and women with learning disabilities died 29 years younger than women in the general population. Over a quarter of the deaths of people with learning disabilities were of people under the age of 50, and that's compared with 5% in the general population of England and Wales aged 4 years and over who died in 2016. So it identifies a greater disparity in age at death between people with learning disabilities and the general population than previously identified, particularly in the confidential inquiry into premature deaths of people with learning disabilities. And what we're finding in common with other data sources, both national and international, and as described by Giles, is the longevity advantage for men with learning disabilities, which is not the case in the general population, and we've not yet explained this. The next slide shows the findings relating to the cause of death. We have less data and possibly less robust data about the causes of death of people whose deaths were reported to the LEADER programme. Partly that's because the cause of death was not always reported at the notification of the death and would only be confirmed during the course of the review. In part, it's also because we're awaiting data linkage between the NHS numbers of people with learning disabilities who have died and the NHS Digital Office for National Statistics coding for the causes of death. But of the 576 deaths for which we have cause of death data, pneumonia caused by an infection was mentioned 16% of times anywhere on part 1 of the medical certificate of cause of death. Sepsis was mentioned in just over 1 in 10 deaths, and aspiration pneumonia in just under 1 in 10 deaths. It's been really instructive for us to look at all of the causes of death listed in part 1, because by looking only at the underlying cause of death, we would miss contributory causes of death that could potentially be ameliorated, such as sepsis. And John will talk in a few minutes about some of the work that's been started now in relation to sepsis with people with learning disabilities. Looking only at the underlying causes of death, diseases of the respiratory system accounted for almost a third of death, and those were almost entirely pneumonia or aspiration pneumonia. Diseases of the circulatory system were the underlying cause of death in 16% of deaths, and cancers in 10%. The next slide shows the assessment of care. So reviewers are asked to assess the care provided to the person who died based on the information they have in the mortality review. Some reviewers grade this independently, some grade the care in conjunction with a leader programme, local area contact, or a steering group. Of the 103 completed reviews, reviewers graded 44% of people who had died as having received excellent care. I've given you an example of the rationale for the grading of one person's care as excellent in the slide. And the reviewer wrote, the family actively participated in discussions with the multidisciplinary team and in planning Jenny's end-of-life care. This was facilitated by a high level of communication between the many acute, critical care, palliative care and community professionals involved in her care, as well as by a clear and organised plan for managing her transfer back to the care home and her management there. I would like to stress that we have changed the names of the case examples we have given so that people are anonymised. Conversely, the next slide shows the assessment of care where care has been found to be falling short of good practice. Of the 103 completed reviews, reviewers graded 10 or 10% as falling short of current best practice. And the rationale for one reviewer grading care in this way is described here. The reviewer wrote, there was evidence to indicate several omissions occurred within the hospital which caused delays in care and treatment provided to Marlon. He was not monitored in terms of modified early warning system measurements, and no blood tests were taken during his brief stay in hospital. There was no documentation in the medical or nursing records to justify these courses of action. The next slide shows some of the learning that's been identified as a result of the mortality reviews. Looking at the 103 completed reviews, the most commonly reported learning and recommendations were made in relation to the need for greater interagency collaboration, including communication, greater awareness of the needs of people with learning disabilities, and a greater understanding and application of the Mental Capacity Act. And these are broadly similar issues that have been identified in previous reports dating back a decade or more ago, which is hugely disappointing. The next slide shows some of the recommendations that we've developed. We made 9 recommendations based on the completed mortality reviews to date. The first is to strengthen collaboration, information sharing and effective communication between different care providers or agencies. The second is to push forward the integration of health and social care records to ensure that agencies can communicate effectively and share relevant information in a timely way. The third is that health action plans should be shared with relevant health and social care agencies with the person's consent or as part of a best interest decision. And fourth, that all people with learning disabilities with 2 or more long-term conditions, either physical or mental, should have a local named healthcare coordinator. The next slide presents the next set of recommendations. So fifth, that providers should clearly identify people requiring the provision of reasonable adjustments, record the adjustments that are required, and regularly audit their provision. 6 is that mandatory learning disability awareness training should be provided to all staff, delivered in conjunction with people with learning disabilities and their families. 7th, that there should be a national focus on pneumonia and sepsis in people with learning disabilities to raise awareness about their prevention, identification and early treatment. The next slide shows the remaining recommendations. 8th, that local services should strengthen their governance in relation to adherence to the Mental Capacity Act and provide training and audit the compliance on the ground so that professionals fully appreciate the requirements of the Act in relation to their role. 9th, that a strategic approach is required nationally for the training of those conducting mortality reviews or investigations, with a core module about the principles of undertaking reviews or investigations and additional tailored modules for the different mortality reviews or investigations. John is now going to talk about some of the national level actions that have been taken forward in relation to the findings presented here.
Okay, thank you very much, Pauline and Giles. So over my slides, I'm going to talk a bit about what NHS England has already got in action to help address this significant concern and problem, and then talk about some work that's actually going to be coming out in the coming months and also some future work that's happening. So on my first slide, I'll talk about the existing NHS England work programmes already established that contribute to reducing premature mortality. So many of you on the webinar today will be aware of annual health checks and GP registers. So this is a programme of work to ensure that everybody in a community with a learning disability is on their local GP register, and being on the GP register then gets you better access to healthcare and an annual health check, which is a good check over to look for any early signs of illness and to help signpost people to sources of well-being and healthy living. So a key measure in reducing premature mortality. There's also a piece of work there called the NHS Digital Reasonable Adjustment Flagging Project, which is a piece of work that addresses some of the recommendations about electronic information systems. And this is a project that, in simple terms, will be able to put a marker on an individual's electronic record, as long as they consent to that says this person needs a reasonable adjustment. And that could be for anybody, and the reasonable adjustment flag would then track through to some information that could be quite bespoke to the individual. So anyone accessing primary care or urgent health care in a situation when they're poorly or going to a screening appointment would have information for the professional there ahead of time to say this person needs a reasonable adjustment. And that can be something as simple as a bit longer appointment, easy read materials, or to engage other professionals or other sources of support for the individual to make sure that they have a good experience in healthcare. The summary care record, additional information, which is something that's already in place. So on people's electronic health records, there's facility to have a summary care record and a space for additional information. This again can list reasonable adjustments and care plans for people. It links very much into the work of the annual health check, people's health action plans, and again is a facility for professionals to be able to share information. The Right Cares pathway work, which is linked to mortality thematic learning, which I'll come on to in a bit more detail in the next slide, is a project about producing best practice pathways for commissioning and practice to address some of the most significant causes of premature mortality for people with a learning disability. I'll talk a bit more about that on the next slide. The flu vaccination promotion programme is something that we're doing this year in partnership with Public Health England and other stakeholders to really drive up the take-up of flu vaccination for people with a learning disability. And there's lots of good work we can do around that, around prescribing guidance, promotion, access to nasal sprays for people that have problems with needles. So some work happening there. STOMP, which is a programme about reducing over-medication, which obviously can link into mortality in certain situations. I think there's been lots of information about STOMP out there, and there's some links at the end of our presentation here, which I recommend anyone who hasn't heard about that to click onto that. And last and absolutely not least is this list of information is not ranked in any way. It's the NHS England work that's supporting the rollout of the LEADER programme operationally across CCG areas. So this is work about helping areas to be able to get ready to deliver reviews deliver the reviews in an efficient and sustainable way, and then make sure the learning feeds back into local action. We're putting more money into that this year to help better establish the programme in CCG areas. So over to my next slide, please. Okay, so this slide's a bit more detail about the right care pathways work for learning disabilities. This piece of work was set up last year, and it's linked to the thematic causes of mortality that come from premature mortality reviews and came from reviews such as the SIPOLD review. So there was some work published on a learning disabilities pathway for diabetes last year. There's a reasonable adjustments pathway that's going to be done. We've been doing this with the Right Care Group, which is an NHS England project about using best evidence and health intelligence and cost effectiveness of care and how to do things better in health and social care systems for commissioners and providers. And there's a piece of work there. The reasonable adjustments pathway is a detailed guidance for commissioners on how reasonable adjustments can be woven into any piece of commissioning healthcare. We've also got some work that's very, very close to completion. We're just going through the graphic design stages about dysphagia pathway. So those of you know that dysphagia is difficulties with swallowing and very, very closely linked to aspiration pneumonia. We've also got a pathway being developed on the Right Care format for epilepsy. And this year we're working on the sepsis and constipation pathways as well. So this work is very, very closely linked and informed from the learning coming from the LEADER programme. So to my next slide. Thank you. So a group that we established this year to really accelerate the learning into action that's arising from LEADER and premature mortality reviews is a group that brings together a range of NHS providers, social care, arm's length bodies such as NHS Improvement, NHS Resolution, organisations such as the Royal College of Nursing, urgent care work. And what it's to do is to better coordinate and signpost best practice and fill in the gaps, if you will. So we know from our learning that we need to get better guidance around Mental Capacity Act and urgent healthcare situations. So we've got a subgroup that's helping to develop that guidance. We're also joining up with the sepsis programme, the National Sepsis Programme, and in July we've got a national workshop on how we can do better work regarding sepsis prevention, detection and treatment for people with a learning disability. We've got work happening on dysphagia, as I've said, pneumonia and constipation and epilepsy. This is very sort of practical, almost technical health work really in developing best practice, joining up existing work that's going well. There's been some fantastic work done in Hertfordshire. I don't know if any of you saw the Woolly LD nurse chat about sepsis, where they've developed really good easy read materials about sepsis identification. So this programme is very much about producing really practical tools for the system and sharing that. So that's something that we're quite excited about it in getting right into the core issues of premature mortality to prevent people dying too young. And my last bullet point there is that there's a detailed response to the recent LEADER reports with wider recommendations being developed in partnership with our arm's length bodies around some of the issues around Mental Capacity Act and training and electronic record systems, etc. So some further work on that due to come out from the system in the near future. So thank you, Donna. That's the end of my slides.
Thanks very much, John and Pauline and Giles. I'm just going to flick back quickly to one of the earlier slides. Giles, we've had a couple of questions in about the data that you showed on slides 5 and 6, just asking about the sample size that those are based on.
Those are data which are taken from death certification data for the whole country, and they are somewhat imperfect because they identify death certificates which specifically say that a person either had learning disabilities or say they'd got something like Down syndrome, where we can reasonably certainly assume they had a learning disability. So that picks up about 1,200 deaths a year, of which about the usual proportion, about sort of 60% of those will be male and about 40% of those will be female. So it's clearly quite a lot fewer than all of them. That's only about a third of the number that we would be expecting to see in the learning disability health and care data set. So 2/3 of people with a learning disability who die don't have it recorded on their death certificate. And there's no reason why they should necessarily have it recorded on their death certificate if it wasn't specifically considered to be a cause of death.
Thanks very much, Charles. I hope that answers the question about that. If there are any more questions on the data, then do drop us an email. John, we've got one for you about the NHS digital reasonable adjustment flagging and whether that can be used on any clinical system. Are you still able to hear us, John? No, I'm not sure whether we've lost John's connection. So apologies, I don't think we can answer that now, but I will keep that question and forward it to John so that it can be answered after the webinar. So apologies for that. Right, we're going to pause for a moment because we've come to the end of the main part of the webinar. We will be coming to a more open question and answer session in just a moment. I'm going to leave this slide up while we just pause, and we'll end the recording now. This shows you where you can get some other information and also our email address again. There are 2 or 3 more slides after this which give links to more resources, so do use those. And as I said at the beginning, please, if you have any more questions after this, do email us LDT at phe.gov.uk. So there'll just be a brief pause and then we'll open question and answers. Thank you.